Well, good afternoon, everyone, and thanks so much for joining today's Breathing Policy Forum. My name is George Habib, and I'm the President and CEO for the Lung Health Foundation. We began the Breathing ago because we saw the many gaps and challenges facing our healthcare system that needed to be addressed. And addressing gaps and inequity. These forums have allowed to bring together different health experts and thought leaders from across the country to facilitate discussions on some of the most urgent issues facing healthcare today. Today is the first of a three focused on COVID-19, marking an exciting new partnership between the Lung Health Foundation and McMaster University's Global Nexus for Pandemics and Biological Threats. This partnership has allowed us to provide Canadians with evidence-based, timely information on COVID-19 vaccine efficacy, infectious respiratory diseases, and other public health measures put in place to manage risk and improve people's health. In addition to this, we're collaborating to advance policy recommendations and solutions to decision makers for some of the major issues associated with COVID-19. Today's discussion will be the beginning of this important work as panelists take a deep dive into how Canada responded to testing for COVID-19 and where we fell short. At the onset of the pandemic, Canadians dealt with considerable lines at testing centers and prolonged waits for test results. Government testing guidelines changed often, with officials struggling with which populations to prioritize as to not overwhelm our labs. Meanwhile, countries across the world ramped up the types and number of tests being conducted. Today's conversation will shed light on how our health systems can be strengthened to improve diagnostic testing, capacity, and reporting. Before I turn it over to our moderator, I'd like to thank our three distinguished panelists, Dr. Smaill, Dr. Buehler, and Dr. Earn for being here today. These three McMaster researchers are leading experts in the areas of infectious disease, pathology, and epidemiology. Without further ado, it's my pleasure to introduce today's moderator, Heather Bakken. Heather is the publisher and Vice President of Business Development at iPolitics and Queen's Park Briefing. She currently serves as the President of World Press Freedom Canada, the past president of the Canadian Club of Ottawa, and founding president of the Ottawa Debating Society. Heather is a graduate of Ryerson University, and go Ryerson, my sister is a graduate from there, and received her certification in digital communications management strategy from the University of Toronto. Prior to joining iPolitics, she taught media law at Algonquin College and was a broadcast journalist with CBC News. Welcome, Heather. Thanks for doing this, and I'll turn it over to you.
Thanks very much, George. I really appreciate that. As you mentioned, we have a powerhouse of panelists that us mere mortals can really learn from, I think, today. To introduce them, I feel that they would be best served by introducing themselves. And I would like to start with Dr. Fiona Smaill, who I would consider Canada's Dr. Fauci, or Dr. Fauci should be considered the US's Dr. Smaill. So Dr. Smaill.
Well, thank you very much for that. And to be compared to Dr. Fauci is indeed an honor. I'm an infectious disease physician and medical microbiologist. And in fact, most of my clinical work has been in the area of HIV. And so Dr. Fauci and I have been very involved in the developments that have occurred in HIV, and also, as I think this affects the challenges we have with SARS, the social inequities that do impact so many of our diseases. So HIV has been one of my major areas of research. I don't know whether it's fortunate or not, but I was here for the first SARS outbreak and recall very clearly the anxiety we had around that, the structures we had, and more importantly, we didn't have in place to manage the concern we had around the outbreak of SARS-1, I can call it that. So we were fortunate. We had a nice 20-year interval, and then, of course, SARS-2 arrived. And so I've been very involved with both looking at some of the clinical management of patients, watching very carefully the clinical trials as they have very quickly evolved, and working very closely with the laboratory in terms of diagnosis. So I'm looking forward to being able to share my thoughts on where we are and where we have to be to manage this going forward. Thank you.
Thank you very much, Dr. Smaill. And I think one of the things we should be touching on, hopefully during this conversation, is the anxiety. My son's name is Sar, and he was very young, having a snowball fight at the Art Gallery of Ontario during the SARS crisis. And myself and my friend said, "Sar!" And everybody ran the other way. It was so bizarre to have that. So anxiety is a big part of what we'll be talking about today on a big scale. I would like to also have Dr. David Buehler introduce himself. The reason that we're using the honorific today, by the way, for these mighty panelists is they're all very lovely and human and accessible, and I'm sure would prefer to use their first name. But we have two Davids, and because there are two Davids, we're going to go with the honorific of doctor. Dr. Buehler, will you please let the audience know who you are?
Sure. My name is David Buehler. I'm an assistant professor in the Department of Pathology and Molecular Medicine. Through this, like prior to the pandemic, our group really focused on looking at the whole testing process from the pre-analytical step where we actually find a way to sample from a patient to collect, the best way to detect a certain type of disease or virus or bacteria. And then we also look at ways to develop better tests for these bacteria and different pathogens as well. But then through this pandemic, we really got involved in finding ways to address not only inequities in testing in the province of Ontario by developing wide-scale screening programs in homeless populations, that finding ways to swab people in the middle of encampments and getting vaccines to them, to also running one of the largest travel studies in North America, if not the world, at Pearson International Airport, looking at travelers coming into the country to get a better sense of how does COVID spread, so we get a better sense of what's getting into this country, informing how we should be quarantining and how long. So it's kind of our shtick right now.
And you're a little bit humble. One of the quotes that I read about you was effectively rebuilt and secured an entire supply chain for testing supplies. And you took the capacity from about 800 a day to 6,000 a day, or potentially. I hope that's accurate.
Yeah, yeah. So as part of the work that we do, we worked with a lot of provincial labs across the province that are in the provincial diagnostic network. And some of the work that we've done, the tests that we developed in our lab has been now run probably over 2 million times in just the province alone. So it's been thank you for that. But yeah, it's we love what we do.
And now kind of leading this all as the Faculty of Science Research Chair in Mathematical Epidemiology. I think one of the requests that I have first off for Dr. Ern is that if you could be our human countdown clock and just let me know when we need to go into the Q&A and when we're done, that would be much appreciated. Dr. Ern, could you please introduce yourself to the audience?
Sure. So I'm David Ern. I'm a mathematician and a professor in the Department of Mathematics and Statistics at McMaster. And I've worked on many things over the years, but for the last 20 years, I have mostly focused on infectious disease dynamics. So studying patterns of epidemics using mathematical models and statistics. And I've had a special interest in studying historical epidemics. So much of the work that I've done over the years has been about epidemics and pandemics that have occurred a long time ago, even going back to the Black Death in the 14th century, and certainly the 1918 flu just over 100 years ago, and many other pathogens. So with that background, it was unsurprising that when the COVID-19 pandemic began, I was asked to join the modeling consensus table, which was later partnered with the Ontario Science Table, and provides advice to the government about COVID. And we regularly submit analyses and forecasts of what the best that we can do to try and figure out what might happen under various scenarios going forward. And that's been going on for the last year and a half. So that's my background, and I am somebody who is not involved in policy directly, but my skills are used to try and provide evidence based on modeling that might be helpful for people who have to make those difficult decisions.
Well, I think we should all be wearing t-shirts saying "No modeling, no future." So perhaps we could kick off with you, Dr. Ern, and just provide us with an overview, because you said you did, the analyses and forecasting for something that did end up clearly being applied at some level, whether or not it was satisfactorily to the decision makers and policy makers. It clearly must have had an impact. So how would you say that the different jurisdictions across Canada on the whole, if you could provide an overview, responded to testing for COVID-19?
Responded to testing. So I guess, my perspective is about modeling. So when you say how the different jurisdictions responded, the other thing that I have to say is that I'm working in Ontario, and my familiarity with how modelers in other parts of the country responded to information about testing and other things is indirect. So most of what I would have to say is about my experience in dealing with Ontario. So we use, every time somebody is infected and tested, eventually there's a report that's made, and those reports come through eventually to people like me who are trying to understand the patterns of epidemics and of the epidemic. And we use those in mathematical models, which means that we have a mathematical framework that captures the mechanisms of disease spread, and we use the reported cases, hospitalizations, deaths, and anything else that we can get to try and calibrate our model. That is, to get things right so that we can explain what's happened so far, and then project forward using the model based on scenarios of what policies people think might be feasible to implement. So, for example, if early on there was people weren't wearing masks, what's the effect of wearing masks? What's the effect of closing schools? What's the effect of closing businesses? And we do our best to answer those questions, though it is always indirect, because we can't actually measure directly the effects of mask wearing or closing businesses and so on. What we can do is make projections based on scenarios. So if wearing masks or doing X, Y, or Z reduces contact or reduces transmission by some factor, then we can predict what will happen going forward. And those are the types of projections that we make. And there's always uncertainty in the projections that we make, not least because we can't directly measure the impact of the different policies that can be implemented.
Yes, fully appreciated. Thank you for that. Dr. Smaill, I think this is in your wheelhouse. You've had a lot of experience with this. How would you respond to that as an overview of how this was kind of managed and handled from a jurisdictional perspective?
Well, I'm going to take a step back and just mention a Little bit about how laboratory testing used to happen. We have private labs, and some of you will go to a private lab to get your blood test done. Within hospitals, we've got hospital laboratories where samples are tested. Some of our hospitals are, of course, academic hospitals, such as the one at McMaster, where we have a greater range and a greater opportunity to develop new tests. And then we have the public health laboratories across the country. And of course, these are provincial. There was usually a central public health laboratory and then a number of peripheral labs. The testing that they used to do was, if a swab goes in for chlamydia or gonorrhea, or a stool goes in to see whether you've picked up salmonella infection from eating an undercooked hamburger. That was probably the focus of a lot of public health laboratory testing. And then there was the exotic testing. So if somebody came back from Central Africa and there was a worry about Ebola, our public health laboratories would do that. So when SARS came along at the beginning of 2020, our laboratories were not really set up to quickly start the sort of testing that David's talking about in terms of needing that information quickly. Many of our processes were still very manual, whereas if you're talking about a large number of tests to be done, you're going to be looking at some robotic or automated testing process. We were quite fortunate that early in January, the sequence of the SARS virus was made available, and this was sort of openly made available to everybody, who then could develop their own tests. So across Canada, we had both public health labs as well as our academic labs, and you've heard what we did in Hamilton, developing very quickly a test for it. So we did have the knowledge to do this. The challenge was, how was all of this going to very quickly get to where it was needed? Who would be tested? How would we test them? How would we get the results? How would we be able to automate some of the testing in terms of collecting those data? Unfortunately, we didn't have a robust system, a lab information system. A lot of things were still done very manually. So one of the challenges we've had over this period of time, and I can speak again mostly to the Ontario scene, is we've been having to build a system to actually allow us to get the information that we need. And this I think did set us back early on. And I don't think we in Ontario were that different from other places. Some were a little further ahead with some of their laboratory information system that would talk to hospitals, talk to private labs, and had a good way of recording the details of patients. But it took us quite a while to get that information up and running. So I think just by presenting how it happened, I hope I've been able to give you a sense of what I saw unfolding over at least the first few months as to how we were managing this.
Thank you, Dr. Smaill. And Dr. Buehler, in addition to some of those challenges that were just mentioned, of course, supply chains, once the testing was used, could you please shed some light on just why we experienced those supply shortages, and maybe just talk a little bit about how you were to break through that, and what's happening now moving forward?
So it's kind of a perfect storm of events when all of a sudden you have this test that needs to be run by every single lab that obviously not in a position to scale to the volume that they need to provide the amount of tests per day that they need. And they basically all, at least in the Ontario realm, that a lot of labs had very similar infrastructure. And so at the end of the day, they have a lot of sites that end up competing for the same resources. And then they're in competition with, not only other provinces, but other countries. And just when you start to look at kind of every part of the testing process, even from the sample collection point of view, when you have a swab that needs to be, into someone's nose, one of the largest manufacturers for that was in northern Italy, and they got hit really hard the first 2-3 weeks of March, and they shut down production. They weren't able to get out to the supplies, and it was to the point where even the U.S. military was actually flying in planes to get these sampling swabs from this company directly. So then automatically, labs in Ontario are scrambling to get that. And then you also need all the chemicals that go with all that sampling process, which, there's very limited supply or even production capacity for that in Canada. So then we're again limited by what we have in the country and have to go outside. And when there is, this view of, nationalism and protectionism and not being able to share these or allow stuff to cross the border, we get we get to the point where people are, having to shift to other labs and send samples to them because they don't actually have the samples the reagents to do the testing. And I think that this all comes back to there's been a lot of issues with, the lack of, medical diagnostic manufacturing capacity in Canada. There is just truly a paucity of, that expertise to provide, medical grade plastics, or even though we have a lot of the raw components that get put into making, chemical common plastics such as like polypropylene, we don't have anyone really in Canada that's making these types of materials. And that's where, we spent a lot of time trying to figure out how we can actually recreate that chain to secure a supply chain that's within Canada so that we can actually maintain this testing, because with the path that it was going, everything was starting to run out, and even the equipment that people are wanting to buy, everyone was just competing for each other.
So it sounds like there's an opportunity for additional innovation. We have taken a few strides, which I think we can touch on a little bit further down the conversation, but thank you for kind of providing that landscape of what you were all up against. Dr. Smaill, can we just circle back to you for maybe some of the people who are watching right now may not understand the different types of tests and how they are used? Could you just give us a little kind of bullet point on that?
So the main test that we rely mostly on, because it has good performance characteristics, good sensitivity, good specificity, is the PCR test, a molecular test. This detects the virus itself in the sample, and that's why often we do the nasopharyngeal aspirate, sometimes a nasal oral swab, to actually get that sample. So we've often used that as the gold standard. Often with some viruses, we would try to culture this, but it's both risky from a biosafety point of view, and it's not an easy virus to culture. So we don't try to grow the virus. We try to detect the virus with what we call the polymerase chain reaction, PCR. So that really is the standard that we measure everything else against. There are some antigen tests which are designed to pick up the proteins that the virus, the components of the virus. These, and some of you may be familiar with the PanBio, which is the one of the commercial strain types of tests. This has probably less sensitivity. We estimate it somewhere around 50% as compared to what we call our gold standard, the PCR. But it does have some advantages, that it can be done in settings outside of a laboratory, and it really is used as a point of care test. You can get a result very quickly. The other test that you may hear about is an antibody test. Antibodies measure the body's reaction to a virus, and generally can be used in certain situations to tell whether you've had an infection, or in other situations whether you are in fact immune because you've been vaccinated. But for the SARS coronavirus, the antibodies are not as reliable, and really in terms of any testing, I don't recommend them either to check whether a vaccine has worked, and would discourage that. And similarly, the antibodies after you've had an infection are very variable and not predictable in terms of, did infection occur, when did it occur? So antibody tests may be helpful for population surveillance, but for an individual, they're not recommended, and we really don't use them very often.
So with the kind of the evolution of the variants that are coming forward and the mutations, are you seeing any, will there need to be a fourth opportunity, or is there one of these three that you just mentioned that would be optimal?
With the variant, what you're going to look at is you'll look at the strain of virus that you've identified by your PCR test, and then it will go on to have some additional testing, which we call whole genome sequencing, which is to look at that strain of virus and determine, is it a variant of concern? And we can also tell whether strains are related to each other by that testing as well, although that's more of a research question. So, and this may be something that we can discuss in a little bit of detail. The variants of concern, currently we're concerned about the Delta variant. To set up the testing in Canada for the sequencing, particularly, let's say here in Ontario, required a very concerted effort between our public health laboratories, our academic hospital laboratories, and our research laboratories, and our team at McMaster has been involved in this. Again, a complex process, but it's those type of data that can be very helpful to people like David Earn, to look particularly at how different strains of the virus are being transmitted throughout different communities. So the sequencing is sort of another layer to give us more detail about the actual strain of the virus that we detect.
Okay, and you mentioned Dr. Earn, and I guess that's where the modeling kicks in here. I'd just be curious to know what the barriers are with testing data that prevents people like yourself and researchers from developing the level of quality and forecasts and analysis that would have the most impact or the best impact for positive outcomes.
Sure. So, some things I think are fairly intuitive. Clearly, we would do the best possible if we tested everybody constantly and always knew when somebody was infected as soon as they had a positive test. And wouldn't that be fantastic from the point of view of people trying to predict what's going to happen? We're never going to do that. So at the other end, if you only sample 1 in 1,000 people who gets infected, you won't have enough information to do anything and to predict what's going on. So there has to be some kind of balance with being realistic about resources and what can be done. It's supposing that we have a reasonable procedure where we test, say, everybody who's symptomatic and wants to be tested, then it becomes an issue of what information do we have other than the fact that the person was infected. Because the more information that we have, the more likely we are to be able to dissect and understand what's happened so far and to project what's going forward. So, for example, if we know only the numbers of people infected or that have had reports of positive tests each day, that's better than not knowing anything. But it's nowhere near as good as knowing what the distribution of ages was among the individuals, whether those individuals had been vaccinated or not, whether they had been infected previously. That kind of information helps us enormously in understanding what's going on. And when you get to predicting what dangers might arise from new variants, which we can detect through the whole genome sequencing, there we have a big problem, because much of the information that we would really like to have in order to do a good job of predicting what might be going on is collected but not passed on to modelers who can do something with it. So, just having a list of sequences that have been detected on its own is not sufficient for me to try and figure out what the dangers are. We need to know who was infected, why were they infected, why were they tested, why, were they a traveler, were they previously vaccinated or infected? If they did travel, where did they come from? All that kind of information helps us enormously in terms of trying to detect new potentially dangerous variants early enough to do something about the spread within the community.
So it sounds like you have several challenges, all of you. We talked about the infrastructure, so didn't have capacity to do certain things, trying to get things digitized. Now we have a communications issue. And for you, what I'm hearing is, for the policymakers and decision makers who may be watching, this is a privacy issue, because you use a lot of anonymized data, don't you? And then when you look at the patchwork of Canada with the provincial level privacy concerns, it seems like there are a lot of moving parts. So I'm just going to open this up to either of three of you. How do we address that in a human way that creates the ability for you to do your work in the name of public health without infringing on what people perceive to be their freedoms? Because we're not going to get political in this discussion. It's about policy, but we do know that there has been a political lens put on this disease and and how we handle it from a public health perspective. And sometimes there's messaging about freedom, and that's not what we're talking about, right? So how could we address the privacy issues that you have? Maybe what's your key challenge with it, and maybe a solution? Who would like to take that on? Okay, Dr. Ern, I'm going to leave it with you then.
So, I think we clearly need, and I don't know who we is exactly, but we need to have a general discussion about how to address privacy issues in a crisis situation like we've been experiencing for the last 18 months. So that concerns about privacy, which are really important, obviously nobody wants their health information to just be spread to anybody. We need to be able to get information that is critical in terms of understanding spread of disease in a crisis situation that is not impeded by the need to preserve people's privacy. I think my experience is, at least in terms of, we're told, information is not passed on because of privacy concerns, but it seems to me it's completely over the top, because when no information is passed on, or so little information is passed on that we can do our work effectively, it's so against the interests of public health that the way that privacy is tried to be protected, while with good intention, I think preventing the information from being transferred doesn't really protect the privacy of individuals in a significant way, compared to what the situation would be if a lot of the information that we could use was passed on. So I'm not sure exactly what the solution is, but there needs to be some discussion and perhaps some loosening of the protocols that have been put into place at times of crisis, so that important information from a public health point of view is passed on to people who can use it to help control and prevent the crisis from getting worse.
So that kind of leads into what I was going to ask about how, what kind of policy and regulatory changes need to be made to allow researchers to predict the future epidemics of infectious diseases, which is the goal, right? To preempt a lot of this stuff. My recollection, I may be wrong, is that when bird flu was on the horizon, there was a pretty good response and system set up to manage something like that. And I guess our memories are all short. So Dr. Earn, you understand the historical context of this, and we don't need to go into the Roman Empire and how long diseases impacted that and led to the fall. It was actually probably, people say it was politics and other stuff, but it was probably just, waterborne viruses and things that we're dealing with now. So taking your point of a crisis, so public policy, health policy, all of these things that come together, maybe Dr. Smaill, you can address how can people put a critical eye on the lens of a crisis. Like, we're not talking about regular privacy issues. We're talking about the tension between individual privacy and the greater good. Can you just sum that up for someone who doesn't, like me, who doesn't really understand this,
Well, I think on a very individual level, we all want to do the best we can for both ourselves and our families and our communities. But I think that if we focus just on crises and expect it all to come together then, we've missed the opportunity to really look at what are the underlying reasons for this. And I think what's happened is that a significant proportion of our community has lost trust in the organizations, the institutions, and is it, and there's many reasons for that. And as I mentioned at the beginning, I think this is what the response that we're seeing potentially needs to address going forward. Why are we in a situation where testing is lower in populations who are immigrant communities, refugee communities, those individuals? I'm aware also of the stigma of being tested for HIV, of being tested for COVID, and I fell into my HIV trap because I see some similarities. We've got many challenges in our society, and it's sort of getting at that level so that when we do run into a pandemic, we're able to very quickly mobilize what we need to do rather than really start from scratch. So I'm like David, I don't know who we is, I don't know how we fix it, but I think that it's a deeper issue with how we are addressing our communities.
Maybe we should just take a moment to talk about stigma, because you discussed you're all in the Hamilton Ancaster area, and maybe to connect the dots for people when there is a stigma, and it comes back into like, we're, should certain populations have had better testing or access to testing at the very least. You gave an interesting example of an apartment building that had an outbreak, and then Canada both stopped delivering. And so these are people in lower incomes who weren't getting their checks, who couldn't pay their rent. Can you just share a little bit of that human side of how these decisions and the policy has a street level impact of unintended consequences, but maybe just to put it on the radar?
Well, I'm actually going to ask David Buehler to do that, because he was really basically the hands on the ground, experiencing that firsthand with those people. Again, many immigrants with really unstable housing, food security, those real challenges. So maybe I can ask David to really speak to that.
Sure. Yeah. It's testing in some of these populations has been, incredibly difficult, and there have been, consequences of calling, outbreaks there, and it's kind of counter to what you'd think, but you figure once you try and identify positives, you want to use that information to help, guide and ask the questions, how can I help? right? Rather than, oh no, someone's positive, let's just, protect ourselves and not think of it as a community. But as soon as we started identifying positives, and then there was an outbreak called, there was actually, mail delivery stopped. People then were having no ways to get some of the food delivery companies that were, dropping off food. Individuals couldn't even get that delivered to the door. And so, just one scenario was, this mom was positive, single mother. She wasn't getting her check in the mail. She wasn't able to order any food to her apartment that was to get delivered because none of the delivery services would come in the building. So as a result of that, we have to find other ways to support these people. But it's incredibly frustrating because you really think that, out of a time where you actually identify, cases like this in these populations, it should be used to really find ways to help and innovate and, make sure that this community is supported rather than stigmatizing and isolating them even more.
And moving up to maybe just from that micro level, school is around the corner. People are going back to school. We did some reporting on the vaccination rates and the infection rates in lower income neighborhoods are just much higher. So should there be testing at schools from your perspectives on a scientific level? If you were in a position to make that decision, I'd like to hear from each one of you, just like yes or no testing in schools.
Absolutely.
Dr. Smaill?
Yes, focus it where it's needed. I don't believe in widespread asymptomatic testing. The resources needed to do that will detract from where we will get the best benefit.
Dr. Ern?
I mean, I agree with Dr. Smaill. I mean, again, as I said right at the beginning, the best thing from the point of view of understanding what's going on is if we could do, systematically test everybody frequently, but it's just not realistic. And so if you do strictly, random testing of people, whether or not they're symptomatic or not, you may not make the best use of the resource.
So how close are we to testing the correct populations? Have you seen improvement? Are we heading in the right direction?
Yeah. One of the challenges we have is that funding for laboratory testing, particularly for COVID testing, is done by the ministry. And so they define the criteria under which testing can be done. You'll remember perhaps sort of May of 2020, there was a lot of encouragement of widespread asymptomatic testing, which overwhelmed our laboratories and didn't provide the information that we really needed to be able to manage the outbreak. So there has to be a way to support appropriate testing, which may include some degree of surveillance of asymptomatic populations if there's going to be a benefit to that. So it can be challenging, and this is where some of these policy decisions come in to play, how we can accommodate what is being requested of us through the ministry's programs, while at the same time being able to expand those a little to be able to answer some additional questions. So at the moment, yes, we've got good testing of symptomatics. We've got good testing of individuals who are contacts. That part's working well, but we need some way to be ahead of it rather than always reacting, and that can be a challenge in the current environment of how these decisions are being made.
Anybody seeing investments in that give you hope? Dr. Buehler, you looked as though you had a comment on that.
Yeah. Well, it's just if you look at Australia right now, and some of the testing that's out of New South Wales, you're looking at they're doing about 100,000 tests per day, and they're finding over the last few days, gradually increasing 400, 500, 600 cases per day. And you look at the number of tests that, we're doing, at least in Ontario per day, and, the number of cases that we're finding, if in a world of unlimited resources, and this kind of goes back to the policy of like, if we're only going to be funded for what is prescribed from the policy, then it makes it really difficult to try and get that sense of what's actually in the community and actually do that large scale testing. And I think that's is a big barrier.
Okay, so the key takeaway I'm hearing is that the testing has to be accurate. We also have vaccination efficacy, right? Like the rates are going up. Are any of you feeling confident? We are, I guess what they're calling it, a fourth wave, but the number of deaths has diminished. So infection rates going up. Are any of you confident that what tools do we need to continue in this, because we're still in the thick of it? Is there a quick hot take that someone can go back to their office, whether they're make a decision on or share with their team, that would give them an instant kind of ability to action, like make this actionable?
The most important thing is to try and get more people vaccinated, so as quickly as possible. That is the single most effective means we have of reducing the impact of the current wave or any future waves. It is not perfect, but it's the best tool that we have. And beyond that, obviously, there are many members of the population who are not yet approved to be vaccinated. And we have really, because the Delta variant is so contagious, we really have no choice but to continue with public health measures that reduce the chance of transmission in those populations, mask wearing and being conscious of social distancing and so on, which does not mean lockdowns or going crazy, but it means not continuing to pay attention and doing our best, even if we have schools open and businesses open and so on.
Thank you for that. So we have a few questions I'd like to get to in the Q&A, but I'd like to leave with a final note on Dr. Smaill. We were discussing this earlier, and I'm hoping the three of you can just maybe give another kind of speed round of what you would advise. If the goal is to get more people vaccinated, and that's our best defense for now, I think it's safe to say some of the communications and the messaging around that it's improved dramatically. But we need the people who are hesitant to maybe shift over to the willing to do it. How would you advise people to maybe appropriately provide that messaging so you have people get buy-in, as opposed to pulling the moats up and saying, I'm not going to do it? Any tricks of the trade that you've learned out in the field?
I always ask the question, what are your concerns? Because you can't give a spiel as to why vaccination is good. You've got to listen to what that individual is saying and then try to address it. Now, that is what I do one-on-one with my patients. But I think it can be done at a community level, but we have to listen.
Yeah, honestly, we were in an encampment on Sunday and probably spent about 30 minutes just chatting to one person about vaccination. Super hesitant about it, and still won't get the vaccine right now. But having that community engagement and actively listening it's going to take a lot of effort, but it is absolutely worth it. And I think we can get there if we do that.
And Dr. Aaron, we'll leave it with you.
Well, I'm not a physician, and I don't have the direct human contact with so many people who are making this decision. But informally, the people I've had many debates with people, and just anecdotally, I would say that, as Dr. Smaill said, listening to what people's concerns are and identifying whether, for example, we sometimes will be aware that people have the wrong impression and it's easy to deal with. So, for example, I was speaking to somebody who was very hesitant about the vaccine and said, well, but if I'm pretty young, if I get it, I'm probably not going to get sick. And if I interact with a vulnerable person, well, they're vaccinated almost certainly, so I wouldn't worry about it. And I said, well, but the person who's vulnerable and might be immunocompromised might not have had the best response to their vaccine. And you might actually end up infecting such a person, and that could lead to really dire consequences. And the person hadn't thought of that and said, oh, okay, well, that's actually a good argument. So now, I don't know if that person then decided to get vaccinated, but I'm just saying that sometimes if you talk to people and listen to what their concerns are, you may be able to identify and give information that helps them on the road to recognizing the benefits of a vaccine.
Okay, so thank you for that. Let's take it over to a Q&A. Now, there is a lot of interest in going back to the workplace and how that will look, and I guess the safety on there. So how would you position frequent testing as an alternative to providing proof of vaccination for employers?
In a single,
is it sustainable? Is it sustainable?
It is not an alternative to vaccination. It is being positioned as an alternative to vaccination because of the concern about mandating vaccines, but it is not an alternative to vaccination. Will it provide some reassurance to the workplace that the person coming in doesn't have COVID and is going to infect everybody? Maybe a little bit, but it's, in my opinion, it's providing the wrong message. And I am somewhat uncomfortable with this very rapid rollout of pan-bio testing, antigen testing, point of care testing in workplaces as an alternative. So I'm not sure what else we can do, but it may be providing the wrong message.
Has anyone seen any testing hesitancy is one of the questions.
Absolutely. At least from our point of view, a lot of individuals, especially in that low socioeconomic group, they fear the consequences of, someone being positive and not being able to work. If a kid, is ending up being positive and then they can't go to school and they're not able to get support for that kid, then they are going to not be able to work and not have income. And so as a result of that, there's a lot of external pressures that drive it to for that testing hesitancy.
Thank you. There's one that we've touched on, but maybe we could just kind of distill it a little bit. Can you comment on the approach to advantages and drawbacks of asymptomatic testing?
Well, if you test a lot of asymptomatics, then you are likely to pick up infections that you wouldn't see otherwise, and sometimes that will give you a lead into an outbreak in places that you wouldn't have caught otherwise. You have to do rather a lot of asymptomatic testing in order for that to be an extremely effective surveillance strategy. So, and I keep coming back to the same point. The best thing is if we actually were just testing everybody from a modeler's point of view. If we're testing everybody, daily, that would be ideal. We'd pick up the infections, whether they were symptomatic or not. We'd be in such a fabulous place, but it's just not realistic.
And it's not realistic to imagine that we're going to be able to have a testing strategy that will get rid of every last case of COVID. There are going to be cases that will occur. We hope that they will be in people who won't get sick, hospitalized, ICU, and die of it. And that's where the vaccination plays in. The likelihood of our whole society being disrupted is very, very much less. So there's going to have to be a certain level that we end up accepting. And so as we're talking about testing strategies, let's make sure that we don't sort of imply that with good testing, there'll be no COVID and we don't have to worry again. It's not going to be like that for a long time. Testing is a component of managing cases and contacts that we fortunately have been able to, in most situations, use to prevent transmission. And so that really will remain the focus, not picking up every last case.
Okay, thank you. And we have one last question, and then we're going to have to, I guess, wrap it up. This is for you, Dr. Earn. The testing capacity is projected to be reduced in many jurisdictions. How much of a reduction in testing can modeling tolerate and still provide reasonably accurate estimates?
Well, I mean, I don't have a simple answer to that, but and it's a good question. But I guess, you know, if the testing capacity is lower, but we're not in the middle of a surge, then that may be okay, because we'll have still enough capacity to test the, you know, majority of people who want to be tested and have some idea of what's going on. You know, I'm sorry, I haven't done the calculation to try and figure out exactly whether there's a threshold of, you know, it would be the results we would get would be too noisy to say very much at all. As soon as when you reduce the testing rate, then basically the data that we get will be noisier, meaning that there's sort of more randomness in it, there's more fluctuations, and it becomes harder to interpret. And any projections that we make will have wider confidence intervals, meaning that there's bigger errors on anything that we project. So, you know, quantifying that, saying is there an exact amount, I don't have that on my fingertips.
Well, it seems like between the three of you, you're covering the research grounds from the, I guess, from the meta level to the individual level. So it's quantitative and qualitative, very much applicable, very much responsive, very much predictive. And I'm looking forward to the next two parts in this series. I hope that people have really taken away some new insights here and do have some actionable information. And again, I just want to leave on saying that you all have been doing yeoman's work during an historic time, and I'm sure you all have personal stories where this disease has impacted you as well on a personal level. And I think we're all looking in the same direction to get through it the best we can. On that note, I would like to hand, and so thank you, Dr. David Buehler, thank you, Dr. David Smaill, and thank you, Dr. David Earn, for sharing your expertise and insights. And I'd like to hand it over to Dr. Jerry Wright for closing remarks.
Well, thank you so much, Heather, and thanks to all my colleagues here on the panel who've done, I think, a really fantastic job of explaining just how complex the situation is that we've been dealing with. You know, we've heard about the need to build systems from scratch, the challenges of biomanufacturing and supply chains. We're dealing with a brand new virus and what's its genome sequence. How do we deal with data, ethics, privacy versus public good, communication challenges, and trust and evidence. I think this really, in a nutshell, tells us a lot about what we're trying to achieve when we launched McMaster's Global Nexus for Pandemics and Biological Threats. This new initiative at McMaster really is here to try and capture this expertise to deal with these very complex infectious disease problems that, you know, the current one that we're facing, and also the ones that we're going to be dealing with, no doubt, in the future. And so how we respond as a society, how we can be resilient and be ready for the next one is really the objective here at Canada's Global Nexus. When we built the Nexus, we knew that we wanted to collaborate. That's the only way for us to be successful, and partnerships are absolutely essential to bring an end to this pandemic and to have us more prepared for the next. And so that's why we're so happy to have the opportunity to collaborate with the Lung Health Foundation, you know, on today's event and also those coming up in the future. I think these policy forums really enable us to bring our world-class McMaster researchers and clinicians to the table, to give you an opportunity to interact with them, to hear their challenges and the exciting opportunities going forward, because there will be an end to this at some point. As you saw, we've done a lot of work here at McMaster to deal with this global pandemic, and in particular in the area of testing and tracing and modeling, as you heard today. So together, with the Lung Foundation's reach across the country and their track record and advocacy, I'm absolutely convinced that we can really start to make an impact on recommending new policies based on evidence that decision makers in Canada can take in advance to deal with these big challenges. So I hope that the forum today is just the beginning of this conversation around improving some of the diagnostic challenges that we're having, not just in COVID, but in other public health challenges that we're going to continue to face. As Heather mentioned, we have two forums coming up. The next one on September 1st at 2 p.m. Eastern Standard Time is on Canada and the global, Canada's and the global response to COVID-19. So again, that's on September 1st. And then on September 15th, we'll talk about vaccine development and vaccine rollout, which of course was something that was on the top of mind of our panelists today. So if you haven't registered for those, I would encourage you to do so. Tell your friends. Thank you for joining, everyone. If you haven't been vaccinated, please do so. You'll be protecting your community and your family. If you're hesitant, talk to your healthcare providers about that, as Dr. Smaill suggested, and we'll see you again soon. Bye, everybody.
Thank you.